Welcome back, class. We now go to the second part of our discussion on the disorders of the adrenal gland and endocrine hypertension. And in this part, we're going to discuss mineralocorticoid excess and the approach to a patient presenting with an adrenal incidentaloma. So mineralocorticoid excess, the prototypical syndrome will be primary aldosteronism. And primary aldosteronism is the excessive production of aldosterone by the adrenal zona glomerulus, and it's the most common cause of mineralocorticoid excess. The other causes of mineralocorticoid excess are not as common, so we don't really need to go in depth into that. No? So we'll mostly focus on primary aldosteronism. Sometimes also it's called primary hyperaldosteronism. So what are the causes of mineralocorticoid excess? So it could be primary aldosteronism secondary to an adrenal adenoma. So that's what we call your CON syndrome. And in this syndrome, you have autonomous aldosterone excess caused by somatic mutations, no? Causing autonomous production of cells that secrete um, aldosterone resulting in an adenoma. Um, Resulting in an adenoma. So that's called your CON syndrome. So if the primary aldosteronism is caused by an adrenal adenoma, that's what we call CON syndrome. So CON syndrome is not synonymous to primary hyperaldosteronism. Okay? So you can also have primary aldosteronism due to bilateral macronodular hyperplasia or micronodular adrenal hyperplasia. There's also such a condition as glucocorticoid remedial hyperaldosteronism, meaning the hyperaldosteronism is caused by ACTH-driven aldosterone production, no? Because of some problems with your genes. And this is usually treated by suppressing ACTH. So how do we suppress ACTH? We give exogenous steroids. So that's why it's called glucocorticoid remediable hyperaldosteronism. It's a dexamethasone suppressible hyperaldo. And these are other rare causes. So all of these are rare. The most common cause will still be your adrenal adenoma, 60%. Okay? So what happens if you have mineralocorticoid excess? If you have mineralocorticoid excess, remember the effects of your aldosterone is to increase your sodium reabsorption, increase potassium excretion, and increase tubular acid secretion. No? So if you have a patient with hyperaldosteronism, because of the excessive excessive activation of your mineralocorticoid receptor, no, you can have sorry for that. Let me just put on my laser pointer. So you can have, of course, excessive sodium retention, and because of the excessive sodium retention, you will have expansion of your extracellular and plasma volume, resulting in hypertension and peripheral edema. So this is one of the causes of your secondary or endocrine hypertension. And since you can also have potassium depletion because of excessive potassium excretion, resulting in hypokalemia. In patients who present with muscle weakness, overt proximal myopathy, or even hypokalemic paralysis. And since remember your aldosterone causes tubular acid secretion, so if you have excess of that, you will have metabolic alkalosis. And this is because of increased activity of your ENaC, no, in your kidney tubules, causing depletion of your H+. If you deplete your H+, you will have metabolic alkalosis. No? If it's very severe, patients can present with muscle cramps or even tetany. So therefore, no, the clinically your patient will have hypokalemic hypertension. But you have to remember also that not all patients with mineralocorticoid excess present with hypokalemia. Some of them will just have hypertension. No? Usually hypertension in a relatively young patient, usually less than 40 years old. No? So, or a patient with an adrenal incidentaloma and hypertension. No? That can also be a presentation of your mineralocorticoid excess, not necessarily hypokalemia. So hypokalemia is not required to be able to diagnose primary hyperaldosteronism. Other effects of your mineralocorticoid excess, since your aldosterone have direct effects on the vascular system, you can have cardiac remodeling and decrease in cardiac compliance. So patients sometimes will present with LV remodeling, no, in your 2D echo, can have direct damage to the myocardium and even your kidney glomeruli. The clinical hallmark is hypokalemic hypertension. So how to screen, no? So at your level, this is the one that I want you to learn who to screen, no? When do we suspect mineralocorticoid excess? First, this patient should have hypertension. If the patient does not have hypertension, then the likelihood of mineralocorticoid excess is not very high. So that's why it's patients with hypertension and either severe hypertension requiring more than 3 BP drugs, no, or drug resistant, no, despite having more than 3 BP drugs at maximal doses, they would still have hypertension, or those with hypokalemia, either spontaneous or diuretic induced, or patients presenting with adrenal mass with hypertension, or those with a family history of early onset hypertension or cardiovascular events less than 40 years old. So let's say a patient comes to you, a call center agent coming in because of incidental elevated blood pressure. Patient is, let's say, 36 years old. You're already warranted to screen for secondary or endocrine hypertension. Then that includes mineralocorticoid excess. So usually, these patients, we avoid giving spironolactone, eplerenone, amiloride, and triamterene because this can markedly affect your aldosterone-renin ratio, which is your screening test. So in order to not affect the screening test, we try to avoid giving this first until we're sure, no? Until we've been able to do the ARR already. So how to screen? We do an aldosterone-renin ratio, no? So we get usually we order it as that aldosterone-renin ratio, and the lab will get the plasma aldosterone and the plasma renin, and then we compute the ratio, no, on the current blood pressure medication. Sorry. So there are also some medications that may affect your ARR, your beta blockers, your central alpha agonist, NSAIDs, ACE inhibitors, ARBs, renin inhibitors, and even CCBs or your amlodipine. But so if there is a doubt, no, in your aldosterone renin ratio, then you can repeat it and then discontinue these medications for a time. But if your aldosterone renin ratio is already um, typical of a patient with mineralocorticoid excess, then you don't need to discontinue or even repeat the ARR. So, but before you do the screening, make sure that the hypokalemia is corrected first, because a low hypokalemia can cause um, false false positive result. So, if you have hypokalemia, we treat it first usually with potassium tablets, and once the potassium is normal already, then that's the time you do your aldosterone renin ratio. So that's how you screen. If it's negative, then we look for other causes. If it's positive, no, the screening test, we do a confirmatory test. So how do we do? Maybe at this point already, you're highly suspecting endocrine hypertension. Maybe this time you want to consider consulting already with an endocrinologist. But if it turns out to be negative, then you can look for other causes of your secondary hypertension. So how do we do confirmatory testing? Where is my cursor? It's gone. So how do we do confirmatory testing? Usually we do a saline infusion test. What happens if we do your saline infusion test? If you do your saline infusion test, you expand the extracellular volume No, you increase renal perfusion pressure. Remember your renin-angiotensin aldosterone system. No, it will suppress your renin. Now, if you suppress your renin, then you will now expect a low aldosterone. No, so um, if you're unable to suppress your aldosterone with your saline loading test, no, it means that there's really excess. Remember, when we suspect excess, we try to suppress it. This time, how do we try to suppress your aldosterone? We do saline loading. No? Saline loading, if you load the patient with saline solution or even oral sodium, your expectation is that your aldosterone will go down. If it's not, if it remains elevated, then you have excess aldosterone production. And then now you proceed to look for the cause. No? So you do a CT scan. If you do a CT scan, no? You find a unilateral adrenal mass. If the patient is young, most likely that's the cause. No? You then proceed to your unilateral adrenalectomy. If the patient is more than 40 years old, no, and the patient wishes to proceed with surgery, you still have to confirm whether that adrenal adenoma, is it really the one that's causing your mineralocorticoid excess, or it's just an adrenal incidentaloma, and it's actually the contralateral adenoma, that contralateral adrenal gland, that's causing the excess hormone production. So that's why you need to do adrenal vein sampling. So the adrenal vein sampling will point you to which adrenal gland the source of excess aldosterone is coming from, no? Because it doesn't mean that there's an adenoma there that's the source of the excess hormone secretion, because when your age becomes more than 40 years old, the likelihood of just having a non-functioning adrenal incidentaloma increases, no? These are the other causes of potential findings in your CT scan, no? So I will not go deep into this because these are very, very rare, no? But if your adrenal vein sampling is negative, you can consider, or if it's a bilateral micronodular hyperplasia, or the CT scan is normal, no? You can screen for glucocorticoid remedial aldosteronism, as I previously discussed. Or you can just treat the patient with mineralocorticoid receptor antagonist. Sometimes while we're waiting for surgery, we can actually give this already. No? So your drug of choice will be your spironolactone. So your spironolactone is a mineralocorticoid receptor antagonist. So it blocks your mineralocorticoid receptor. No? Usually we start it at either 12.5 to 15 milligrams. So, and it can be titrated up to 400 milligrams to control both the blood pressure and to normalize your potassium. Remember, spironolactone is one of your potassium-sparing diuretics as well. No? So, side effects, you can have menstrual irregularity, decreased libido, and even gynecomastia, especially in males. No? We can also give this, no, in order to control the blood pressure and the potassium prior to surgery. No, others, we have eplerenone, amiloride, but we don't have this locally. No? So these are non-aldosterone related mineralocorticoid excess. You don't really need to know this, just nice to know. Okay, so next we go to your adrenal incidentaloma. So how do we approach a patient coming to us for an incidentally discovered adrenal mass? So let's say the patient undergoes CT scan for another reason. Let's say the patient underwent a CT stonogram for a suspected kidney stone or a suspected intra-abdominal infection, and then they find that there's an adrenal mass, no, in that CT scan. That's your adrenal incidentaloma. and at least 2% on the general population, as documented in CT scan and autopsy series, will have a non-functioning adrenal functioning or a non-functioning adrenal incidentaloma, and the prevalence increases with age. That's why I mentioned to you earlier, in patients with suspected primary hyperaldosteronism more than 40 years old, an adrenal incidentaloma is not equal to Conn syndrome. No? So adrenal incidentaloma, usually they're solitary, can also be part of genetic syndromes such as your multiple endocrine mutation 1 and 2, Carney's complex, McLean-Albright, and majority are endocrine inactive, meaning non-functioning adrenocortical adenomas. But still, up to 25% are hormonally active, either Cushing's syndrome or Conn syndrome or a pheochromocytoma. That's why it's important to work up any patient presenting with an adrenal incidentaloma because they have the potential to be hormonally active. In very rare instances, you can have adrenocortical carcinoma. The more common one will be metastasis, no, originating from another solid tumor, and this is the most common cause of a malignant adrenal mass. No? So a metastatic tumor is more common than an inherent adrenocortical carcinoma. Okay? So if you have an adrenal mass more than 1 cm, it's very important to proceed with a diagnostic evaluation. If it's less than 1 cm, and the patient is otherwise asymptomatic, you may just observe that mass, no? And just follow them up, no? After 6 or 12 months, depending on the patient's symptomatology. So if you are presented with a patient with an adrenal incidentaloma, remember, you again have to answer 2 questions. Is the patient functioning? Meaning, does the tumor autonomously secrete hormones that could have a detrimental effect on health? No? And the next most important question is if the adrenal mass is benign or malignant. So first, is it functioning? Second, is it malignant? So that's the shortcut to these 2 questions. Next, the imaging of choice is CT scan. No? If the pituitary, it's MRI. In the adrenal, it's your CT scan. In children, young adults, and pregnant patients, MRI is the preferred imaging of choice. So, fine needle aspiration biopsy may be indicated in patients with history of a non-adrenal malignancy. Let's say your patient has a breast mass, no? A breast mass, and then they find a newly detected adrenal mass. Then you can consider doing a fine needle aspiration biopsy to check if this is a metastasis already. But be careful, make sure that you work up the patient first. And the most important thing that you have to rule out is the presence of a pheochromocytoma. Because if that adrenal mass is actually a pheochromocytoma, you can trigger a hypertensive crisis, no? Because it will influence therapeutic management. So how do we work up? We work up the different layers of the adrenal glands. No? So the most important thing that we have to rule out is pheochromocytoma because it's the deadliest of all the 3. And how do we screen for pheochromocytoma? We do either a plasma metanephrine or a 24-hour urine metanephrine. Next, we screen for Cushing syndrome. No? So remember how we screen for Cushing syndrome, either a 24-hour urinary free cortisol or midnight salivary cortisol. No? We don't do a midnight plasma cortisol as much anymore. Usually we do a midnight salivary cortisol or a low-dose dexamethasone suppression test. No? At least 2 of the 4 tests. And then if the patient is hypertensive, we screen for CONS. No? If the patient is not hypertensive, we don't screen for CONS anymore. And remember how do we screen for CONS? We do a aldosterone-renin ratio, no? By getting a plasma aldosterone and a plasma renin. If the tumor is more than 2 cm, then you can consider an androgen secreting tumor, but these are very, very rare conditions. So usually we focus on these three. Now, if the patient doesn't have any money, only have money for one test, you screen for pheochromocytoma. If any of these are positive, no, you do confirmatory testing. If it's negative, you just repeat, no, and just screen again after 12 months. If it's negative, then probably it's just an incidental. You don't need to do anything with it. Now, even if it's negative, but the imaging suggests possibility of malignancy, meaning the size is more than 4 cm, and the Huntsville unit or the CT density is more than 20, the CT scan contrast washout is less than 40%, no, then you can recommend unilateral adrenalectomy even if it's non-functioning. But of course, before doing a unilateral adrenalectomy, it's important to screen for this first, no? Because your patient can have an hypertensive crisis in the middle of surgery or prior to induction, even during induction of anesthesia. If the imaging is if the screening test is negative and the imaging is not suggestive of malignancy, then you can just observe the patient. Just repeat the screening test for after 12 months, repeat the imaging, no? Reevaluate if the tumor is growing, no? If the screening tests are negative again and the tumor is not significantly growing, no, then you just follow them up as needed if there are any symptoms new symptoms that happen to the patient. So we mentioned earlier about the rare adrenocortical carcinoma. I think I've only seen about 2 or 3 patients, and that's because I train in a referral center. This is actually very, very rare. The annual incidence is 1 to 2 per million population, and it has to be managed by a multidisciplinary team because this is a very, very fast-growing tumor. No, usually co-managed with an endocrinologist, an oncologist, a surgeon, a radiologist, and a histopathologist. And in these cases, if the CT scan is already indicative of an adrenal cortical carcinoma, you may not do fine needle aspiration biopsy because you might risk spreading the tumors, no, intra-abdominally. So you don't need to do FNA. You just proceed and go straight to adrenalectomy already. And majority of patients with adrenocortical carcinoma show biochemical evidence of steroid hormone production. So they can present with Cushing syndrome or symptoms of androgen excess, no, virility, etc. So very hard to treat. Usually they present late, no. Cure is by early detection and surgical removal. And after that, we treat with Vitatin. Remember, it's an adrenolytic drug, no? Especially in patients that are high risk of recurrence. If the tumor recurs or progresses, we go now to your medical oncologist to help us with a chemotherapy. But overall, the survival of patients with adrenocortical carcinoma is still poor, with 5-year survival rates of 30 to 40% and a median survival of 15 months, no, in metastatic adrenocortical carcinoma. That's why cure is by early detection, but most patients are discovered very late. No? So this is a patient. This is actually an MRI, no, with a right adrenocortical carcinoma that was detected incidentally. And I'm surprised that this was discovered incidentally because the mass is already very, very big. And this is actually an adrenocortical carcinoma. Okay, so that's the end of this part of our lecture series. Our next session will be, the next part of the lecture series will be all about adrenal insufficiency. So I'll see you then.